Let's see if we can move on to cervical cancer during the last part of our discussion here today. And recently we had what we all think is a significant addition to the treatment of cervical cancer based on a gynecologic oncology group trial, GOG 240. So I'll ask Dr. Monk, who's the chair of the GOG Cervix Committee, to kick off the discussion on this.
Yeah, so published almost 2 years ago in the New England Journal, leading to FDA approval last August. Again, the addition of bevacizumab to chemotherapy in the setting of metastatic cervical cancer. So these are patients that are either newly diagnosed with cervical cancer stage 4 or develop metastatic recurrence. And when added to chemotherapy, generally cisplatin and paclitaxel, but also maybe paclitaxel and topotecan, adding bevacizumab improves overall survival by almost 4 months. So all your discussion about PFS and that sort of thing in ovarian cancer may not be relevant to cervical cancer, again, like you said, Tom, because the post-progression survival isn't very long. And practically in cervical cancer, that you can increase the survival from about 11 months to 15 months in recurrent cervical cancer by adding bevacizumab, and that's the label.
Okay. Everybody on the panel use bevacizumab in cervix cancer? Frontline?
Yes.
Pretty much, yeah. Unless, yeah.
I do.
Anything to add to what Brad has said about?
Well, I mean, I can criticize myself. I'm my best critic. Is that we identify?
No, we're better than you.
Yeah, I don't know.
Oh, just wait. We're not done yet.
So this study, though, identified a new toxicity. So we knew that you could get GI perforations with bevacizumab,
Yeah.
but this idea of a vaginal fistula,
Yeah, no
so a
doubt about it.
rectovaginal fistula generally, but also a bladder fistula, is really serious. And
Yeah.
it's not to the level that a patient doesn't generally die of it. When you get a GI perforation in ovarian cancer,
It's
that's
catastrophic.
generally lethal.
Yeah.
But getting a vaginal fistula may not be lethal, but it's catastrophic.
Yeah.
And the risk is 8%.
Yeah.
And an 8% vaginal fistula rate has to be weighed against the 4-month improvement overall survival.
Yeah, I have to admit, I was going to couch my statement because I get very nervous about that, the inflammatory response you see in the pelvis sometimes, and sometimes I'll avoid it in patients who I think have that, especially if they've got already evidence of proctitis or radiation cystitis. I just think it's a setup for a failure. It's a wound. It's a
It's a wound healing. It's a wound healing,
and we know that wound healing is disrupted by anti-VEGF therapy.
Other comments, Tom?
No, I think it's been said.
Okay, so that I think, is it fair to say, would the panel agree with the statement that the current standard of care for metastatic cervix cancer would be a combination of paclitaxel, cisplatin, and bevacizumab based on the data that we have? Okay.
And it's
Come on, Angela's going to say I actually individualized the patient.
I do. I have to go back to that.
She substitutes
You know,
carboplatin.
I
Again,
do.
this is the only NCCN level 1.
Yeah.
Yeah,
And this is
It's
NCCN
absolutely-
level 1.
yeah.
It's been twice,
It
right?
absolutely
We've done it twice.
represents a standard of care, but you could also treat the patient with these agents and no bevacizumab based on concerns about toxicity.
Yeah.
Nobody's going to argue with there.
Okay, I take it when you do that, though, you do explain to the patient that adding bevacizumab improves survival?
Oh, absolutely, and they
Okay.
refer them to you.
Yeah, okay, thank you. All right. The